Good morning, everybody. I'm Dr. Wang Yingwei. I'm the professor in Tsuchi University and also the consultant in Hualien Tsuchi General Hospital. I'm also the former Director General in Health Promotion Administration. Today, we are going to discuss the topic about health literacy and also cultural competence in healthcare professional education. This is the title that we are going to discuss. The first about the health promotion and health literacy. The second is about the health literacy for non-communicable disease. The third is about the health literacy and culture. And the fourth is culture competence for health promotion. And finally, we do some conclusion. When we look at this figure, we notice that there are a lot of changes globally, including the aging population growing very fast, globalization, migration, climate change, multimorbidities, and infectious disease. This is why UN proposed about the SDG. And when we're talking about the migration, talking about the aging, we are talking about something related with the culture. So first, what is health promotion? Health promotion enable people to increase control and over their own health. It covered wide range of social and environmental interventions that are designed to benefit and protect individuals' people's health and quality of life by addressing and preventing the root cause of the ill health, not just focusing on the treatment and cure. But if we use one word to describe about the health promotion, we use the word empowerment. This is the definition by WHO in 1986. The key concept of health promotion related with the Ottawa Charter in 1986. It emphasized on the 5 domains and 3 strategies. The 5 domains including the building public health policies, creating supportive environment, strengthening community actions, developing personal skills, and beyond the health service. And the 3 major strategies, including enable, mediate, and advocate. In 2016, the 9th Global Conference on Health Promotion in Shanghai, they proposed the Shanghai Declaration about health promotion. And in this the conference, they emphasized that there are 3 pillars. One is the good government. The second is about the healthy cities. And third is about the health literacy. And health literacy is an important factor in improving health outcomes. It increases the knowledge to help people to make healthiest choice and decision for themselves or their families to achieve the goal about the empower citizens and reduce health inequalities. This is the summary of the development of the health promotion. At the basement that is the 1986 about the Ottawa Charter, there are 5 domains, including the public health policies, a supportive environment, strengthening community actions, developing personal skills, and mental health service. After almost 10 years in 1997, in Jakarta Declaration, they emphasized that to approach this health promotion should start with the setting. So health promoting hospitals, health promoting schools, healthy workplace, healthy cities, all are settings that we can target our population in these settings. And also they emphasize that we should use the 5 domains all together, not just one by one. And about in 2005, this Bangkok Charter it emphasized on the health promotion in a globalized world. In 2016, Shanghai Charter, it emphasized on healthy cities and health literacy. The most recent health promotion conference is the 10th Global Conference on Health Promotion in Geneva. And during this conference, they proposed the Geneva Charter for Well-being. From this time, we not only emphasize on health promotion, we also putting the concept of well-being as a more positive health. The Geneva Charter for Well-being expressed the urgency of creating a sustainable well-being societies committed to achieving equitable health now and for future generations without breaching ecological limits. For the Geneva Charter of Well-being, they are stewarding a flourishing future, and they emphasize that through the education, culturally relevant health literacy, meaningful empowerment and engagement. This is the very important concept, and this is the title that we are going to discuss in these topics. And we should approach in all settings and also through the life course, including the promotive, preventive, curative, rehabilitative, and also palliative health. And we also noticed that globally, there's NCD is play a major role for the mortalities of human beings. In the past, it's only 4 by 4. The risk factors, there's 4 risk factors, including the tobacco use, unhealthy diet, physical inactivities, and harmful use of alcohol, and targeting on 4 diseases, including the cardiovascular disease, cancers, diabetes, and chronic respiratory disease. But in 2019, the BMJ proposed that there should be a 5+5, including the mental disorder and, for example, the dementia or the stroke. And also the risk factors, including the environmental risk factors, should play very important issues in the development of NCD. There is a very famous model called chronic care models. When you're taking care of the disease in the chronic situations, we have to pay attention, including the communities, the health systems, and, for example, their resources and policies, and also self-management support at the community levels. There are also for the delivery health system design, decision support, clinical information system, and organization of the healthcare belong to the health system. But on the basis of this the model, the so-called informed active patient and prepare proactive practice team. This is a two-way dimension that the interaction between the individual and organization produced as the essential for health chronic care model. This is another model, so-called health literacy social ecological models. You notice that the patient engagement and health literacy are being in the center of these models. When they expand outside, including individual, interpersonal, organization, community, and macro policy. This is a multi-level approach to one issues. But no matter what kind of situation, the patient engagement and health literacy should be the core of the patient-centered care. This is a very simple figure. The left side, that people are passive and they all believe in the doctors and they do not find some information by themselves. After the health literacy intervention, including the decision support, more people are activated and then they start to taking action, find more information and organize questions for themselves. So what is health literacy? This Professor Sharonson in 2012 proposed this model, and this is a very famous model. You can see that notice at the center of it is the knowledge or the competence motivation. And then you notice the dot line, including access of the information, understand of the information, appreciate the information, apply it, and then we do it the health promotion. Start with the healthcare. That is the disease already happened. To the disease prevention. To also outside is the health promotion. And on the right side, you will notice the result. We get some of the health behavior changes, and that will be improved of the health outcome. And we notice that the participation, but also empowerment. So this is a very famous one, including at the dot line, including the assess, understand, appreciate, apply. This is the core concept of health literacy. This is the table that we have a different boxes. For example, the healthcare, when you assess or obtain the information relevant to the health, you can get some information from the healthcare. You can understanding the information. of the healthcare system. And also in different box of the matrix, you have noticed that different action that we have to apply the health literacy and also from healthcare to disease prevention to health promotion. We have mentioned about that to retrieve the information and understand and analyze. There are studies showing that for those people with low literacy, just like the red line, the part that they lack of is about the appraising health information and about the application of health promotions to certain issues. In the past, Taiwan do a lot of health literacy research. For example, for health promotion, there are some literacy about the obesity, nutrition habit, active aging. And for the disease prevention, there are some so-called free high, including hypercholesterolemia, hypertension, or diabetes, high blood sugar, or cancer prevention, osteoporosis prevention. And for the medical care, about the integrated diabetes care, integrated chronic kidney disease care, and also COPD. This is some of the very important topics that in the past we have to put it into some research project. In the previous slide, we're talking about the core concept of health literacy, including the retrieval, understanding, analyze, and utilize of the information. So first, then looks about the information, the quality of the information. First, we have to produce some of the so-called health literacy-friendly materials. There are six criteria for all these materials. This indicator including the content of the materials, the language and style of the materials, how to reorganize and editing of the education material, and also the numerical readings. This means that what's meaning of the numerical? It means that if you're talking something about the percentage, it is something some people do not understand what is mean the percentage. You have to say if there are 100 patients, 90 have happened will happen the disease. So this is 90%, but we don't use 90%. We have to use 100 people in which 90 people get the disease. So this is the so-called numerical readings. And then we evaluate the visual image and also the layout of the design. All the materials, if they have fulfill the criteria or indicator of the health literacy friendly materials, they can go through this process to review whether they fulfill all these indicator. The other thing is about the decision. The decision-making model are uh, there's two parts. One is the doctor, the other is the patient. In the paternalistic aspect, the doctor played a dominant role. In the information part, the patient get the information role and they make the decision. But if the shared role, shared decision-making role, so-called SDM, the doctor and the patient discuss together and then find out the most appropriate decision that to get the best benefit for the patient. So for health literacy, that we mentioned about the shared decision making, and then improve the provider health literacy and also the patient health literacy, and then we can get a healthcare quality improvement. In 2016, 10 hospitals chose chronic disease subjects to implement the SDM model in Taiwan. But now most of the hospitals adopted the so-called shared decision-making model in the hospitals to share the information with the patient and discuss with them together to make the decision. There are another term called the patient decision aid. That means that we have to prepare for material that we can use it as a instrument to discuss with the patient. The criteria for the patient decision aid, including certain criteria, as just mentioned about the content, the numerical, the visual, and also the process. And you can notice that we have a lot of so-called PDA developed from the government, and then we encourage most of the hospitals, they can use these government prepared materials to use this to educate the patient and make the decision with the patient together. And another issue is about the so-called QPL, question prompt list. The question prompt list means that we help assist the patients to make the decision, ask the question. We do some of the study. We have a very small study that they are including experiential intervention, 315 7 patients, and a control 315. For the experienced group, we do the pretest and we use the QPL, the question prompt list. And then after the consultation, we do the post-test. And from this, the results showing that you can notice that the red line and the green line. We notice from the red line and the blue line. The blue line is those people with low literacy. And for the experiential group, before and after, there are some more question asked for after the intervention. That means that for those with the low literacy, if we provide the question prompt list for those people, they engage in the decision process more than before the control group. We also prepare some of the health literate toolkit. This toolkit, we have a 6 toolkit, including the oral communication toolkit, communication with the elderly toolkit, navigation toolkit. For example, when you go to the hospitals or you go to the clinics, how you find the right place or the right ways to do it, to get the result, to get the blood exam, blood drawing, or get the medication. So this is navigation toolkit. And also we have a so-called numerical literacy toolkit and question prompt list toolkit, and also the multimedia toolkit. People can learn, also the provider can learn from all these toolkit, then we can assist the patient to get a more highly engaged in the decision process. We can just look at this one.
Health literacy is about making informed decisions and taking actions to promote and protect health. Health literacy is the degree to which individuals are able to access, understand, evaluate, and communicate information to engage with the demands of different health contexts in order to promote and maintain good health across the life course. Research shows that health-literate patients are more able to make healthy lifestyle choices, have better communication and interaction with healthcare providers, access information and services, manage chronic disease, and engage with health, education, and promotion. Health literacy is also a way to promote, maintain, and improve health across the life course. And health-literate partners consider the role of health literacy in helping patients access, understand, evaluate, and communicate information, resulting in increased effectiveness in treating patients, better patient relationships and communication, and increased efficiency of the entire healthcare system, both public and private. How many Canadians over the age of 16 do you think have low literacy? And what percentage of Canadian seniors have low health literacy? This means that the majority of your patients and clients leave your appointments without understanding what they've been told. Health literacy is a costly problem that will grow as the population ages and chronic diseases increase. Dan is among the 60% of Canadians who do not have the health literacy skills needed to adequately manage their health and healthcare needs. He is 24 years old and his asthma has flared up again. He is back in for a visit to get help. It's important for Dan to get the information and care that he needs in a way that he can understand and use. Health visits can be stressful, anxiousness over a diagnosis, cultural barriers, or hesitation to ask questions due to the authority figure of the doctor or a healthcare provider all affects health literacy. Health literacy has many faces. Everyone can benefit from health literacy, regardless of age, gender, ethnicity, or income. It is a well-recognized asset across the globe as an effective evidence-based strategy for improving health outcomes and reducing healthcare costs. Health literacy is more than giving out health brochures and talking to patients. It's a two-way street. Patients have a role in letting healthcare providers know their concerns and when they don't understand what was said or have questions. And healthcare providers have a role in building a trusting relationship with patients and delivering messages in a way that patients can understand. This takes very little time during an office visit. Ask Me 3 promotes 3 simple but essential questions that patients are encouraged to ask their healthcare providers during every visit. What is my main problem? What do I need to do? Why is it important for me to do this? Providers don't always know which patients have limited health literacy. Health literacy strategies should be used with all patients. 7 practical actions include: look for clues. Common behavioral signs of low health literacy include missed appointments, not writing down instructions, not taking medications, and incomplete forms. Verbal cues include comments such as, "I forgot my glasses, can you read this to me?" Or, "I got confused about my medication." Use audio visuals, models, and pictures instead of written words. These are more effective for patients to understand their health condition. Use demonstration. Highlight or circle any take-home points. Use plain language with your patients and convey the most important concepts first. Speak slowly and avoid acronyms and jargon. Tell Dan that when he leaves here today, a friend or family member is going to ask him about his visit. What will he tell them? The best patient-provider relationships are partnerships. Encourage patients to self-manage and actively participate in their care. Self-care can include encouraging family support, connecting patients with website resources, health education, and other community-based resources. These strategies help promote health literacy and ensure that patients are informed and proactive with their health care.
we're talking about the providers. Uh, we need a health literate environment. Also, we need a health system policies, the process, materials, and relationships that should be health literate appropriate, not only for the individual skills, knowledge, and capacity, but also the situation the patient was facing during the consultation process. And in 2015, in the United States, they proposed the attribute of a health literate healthcare organization. There are some attribute that is suggest that this is the organization that is a health literate appropriate. In Taiwan, we noticed that we have a health promoting hospital campaign since 2006. And till 2018, we are the highest number of the health promoting hospital globally. And because of, there are a lot of accreditation for the health promoting hospitals. In the past, we have baby-friendly hospitals, age-friendly hospitals, green hospitals, health hospitals. There are so many accreditation, and the hospitals feel that this is unbearable because there's too many visits from the accreditation. So we changed to the basic and also we publish some of the health literate organization, the practice guidebook. We put all the examples of how you can deliver a health literate organization in your own organization. So we do it as a guidebook and with a lot of examples during the for the guiding. Not only for the development of some of the guidelines, we started with some of the training program. So there's a module for the concepts and how the verbal communication, how about the module of the written communication, and how to improve the community health literacy. So we prepare a lot of different kind of training program for the healthcare provider program. This is just one of the online examples that doing a physician doing the right or wrong teaching back process, showing the demonstration how to be a good teach back process. And now we're talking about the health literacy development for the prevention and control of non-communicable disease. In 2022 November, WHO released 4 volumes about the so-called health literacy development, prevention, and control of non-communicable disease. The volume 1 is overview, and volume 2 is the globally relevant perspective. Volume 3 is the recommended action, and number 4 is the case studies. These 4 volumes for health literacy, especially target on non-communicable disease, is very comprehensive and very practical, and there are a lot of examples that we can learn from the examples. As we noticed that there are risk factors, and that if we have all those risk factors, then we're going to develop the NCD in the future. But some people do not know that there is a the risk factors related with the NCD. Some people realize that these risk factors are related with NCD, but they do not pay attention on those risk factors. And only a small portion of people they understand that there are risk factors for the future development of NCD, and they pay attention to it and start to change their lifestyle. So this is a different kind of situation that people are facing the NCD. And the concept we start with the setting and social practice and actions and also barriers. So we can discuss step by step. First, how about the settings and health for the settings and health determinants? There are different kinds of settings. Also, the traditional knowledge, the ancestors and religions requirement of health, or the economic and commercial environment, or the real regulation of our legal environments, and the norms and culture. These settings are always assisted before we start our health program. We learn a lot of health information, health knowledge in these so-called traditional settings. And also there are social practice. Through the social practice that we learn the education, the knowledge, there are terms called the mother's need. Mother's need means that when you sit on your mother's and when you are a very young child, you learn something from your mother. And this is the health concept of some of the disease. And also there's some stories and myths, cultures and community practice, families, friends, peers, workplace, health workers, all are social interaction. Through, through this social interaction, we learn something from uh, the, the, our mindset of the disease. And also we have some so-called formal education, including the literacy, numeracy, biological health. There are also conventional and digital media. The conventional, we use the television, the radio, and now we use a lot of social media to get the knowledge. So there is some five actions. We just mentioned about four actions. Actually, in WHO, they mentioned the five actions. One is assessing the information. The second is understanding the information. The third is about appraising the information. The first three are the same as we discussed in the previous slides. And then WHO add another one is about the remembering. Sometimes we just understand, but we forget very fast. And the fourth and the last one is using the information to change their lifestyle. And how can we learn from it? The ways of learning, including in the community conversations, which can use the arts, materials, or use the conventional mass media or digital media. What kind of barriers we are facing when we want to improve the health literacy for the NCD? Uh, Probably the first is about the physical access. We don't have such kind of information center or place that we can access the information. We don't have the appropriate language or the service qualities. Also, the cost of the approaching of this have information, and also there are culturally stigma, sense safety. This is why we are talking about the culture and health literacy. Health literacy. And there are different aspects from individual to the community and interpersonal response to organization and the public policy and society. From the health literacy development, we need to assess all the different levels. And then there are some special target population that we have to target, and then we will change the target population, and then make a big change of the health system. One thing that they mentioned on the WHO model in developed from 2022 in November is about the community health literacy. As we just mentioned about the individual and organization, they also emphasize that patients learn a lot of information from the community. Also, their health behavior are influenced by their colleagues, by their peer, or their friends in the communities. So we need to target also on the knowledge help of the people in the communities. And then we use the information should be trusted and circulate and not freely in the communities. And all this practice should be in the daily life. For the individual health literacy, we not in the past we just focus on the formal education. We know that this health literacy accumulated through the daily activity and social interaction and across generation. We just mentioned about the mother's need. When you're a very young child, you sit on your mother's knee and then you learn something from your mother, from the stories. So this is all the so-called health literacy accumulate in the lifelong course. The concept is about co-design. People with life experience, community members should have learned working together to design an appropriate program in the communities and also for the individuals. We are not only the one people that as a health provider, we are not only provide the pure information. We need to working with the people together to develop appropriate information or health literacy program for our client. In HRQ in the United States, their health literacy universal precaution toolkit. This is a very famous toolkit. There are a lot of more than 20 toolkit in this PDF document. But in the 210, it's called the culture and other consideration. It means that when we consider about the health literacies, we have to consider about the culture issues, including how we learn about your patient's health need and culture aspects. you have to improve cross-cultural communication skills, and we have to avoid stereotyping and consideration to health beliefs and customs, ethnic customs, religious belief, dietary customs, interpersonal customs, and also the expectation. This is emphasized on the Health Literacy Universal Precaution Toolkit number 10, uh, the 210 for all this information. And we also noticed there is a thing about the culture health. Think culture, this is Department of the Health and Human Service Office of the Minority Health. Why we focus on the communication, especially because as a limited health literacy, the language barrier, the culture barrier, that all cause the communication problems. And the communication problems will lead to the patient safety events, greater risk for the medical errors, and high rate of readmission and poor health outcome. So from this original that how to improve the language barrier, culture barriers, and also the health literacy, improve communication, and then solve the future problem. And also in United States, there are articles about the cultural competence education for students in medicines and also in public health. It is including in the core competence for international collaboration practice, including the community and health population oriented and also the patient and family center. There are four domains, including the teamwork, team-based practice, including the communication practice, including the roles and responsibilities, and also the value and ethics for the interprofessional practice. If you come to see that the detail of this core competence, and then including the knowledge, the skills, and attitude. So for the knowledge, they need to define the diversity, including the language and sexual identities, and also the cultural factors that contribute to the overall health. So there are a lot of standards that we need to fulfill during the after completion of the study. Student will be able. So it means that this is the learning objective for the students before they graduate. Then there are also some skills for the cultural competence. Including the culture as a key, incorporate the culture as a key component, engage community partners, demonstrate the shared decision makings, and part of the self-reflection. We practice self-reflection since the year one of the medical students and ask them to write once a week about the diary and do some reflection. And the attitude, the value and belief of the cultural competence, including they want to apply the principle of cultural competence to their patient, to the client. And also they demonstrate the willingness to collaborate with the different culture in the clinical and communities encounter. And for the medical students, most of the medical schools put the ACGME core plan competence domain, sixth domain as the is the graduating objective. These six domains including the medical knowledge, but in each domain there are something related with the culture. For examples, medical knowledge you need to identify cultural factor to contribute to the overall health and wellness, and also describe the value and limitation of the evidence-based literature. So this is for the knowledge, and this is also for the patient care, or related with the cultural issues. It means that the patient, family, and community all together should develop the treatment intervention working together. And also very important about the shared decision making. The interpersonal and communication skills, that means that in each society, there's a culturally issues for the communication, and we have to pay attention to all the issues. The professionalism is one of the six core competence. And the profession relates some of the cultural humanities and cultural diversities. And also they appreciate how culture competence contribute to the plans of medicine and the public health in detail. Very important is that in the app portal, this website, there are a lot of teaching material we can learn, retrieved free of charge from the training materials. For example, there are stereotype and bias for the psychiatric bedside. culture competence in the third year requires classroom. Or there another one program called the narrative reflection in family medicine classroom. Or there's tobacco types, or there is the interpretation of the OBGYN pesticides. And before, so there are a lot of learning activities that we can learn from the daily practice, from the ACGME 6 domain, and also from the WAMC, the American Association of Medical College. They had published many articles, including the assessment change, how we evaluate our students that can get the appropriate culture competence, and how to develop some curriculum change about the culture competence. There's some tools. There's a very famous tools that called the Tool for Assessing Culture Competence Training, TACC. There are 5 domains, including the domain 1 is the culture competence. Domain 2 is about the all key aspect. And the 5th is about the course culture and clinical skills. I don't have many times to go into detail, but we can read from all these articles because they are quite useful and also free of charge. About and there are also some of the cross-cultural communication and negotiation. Some models. I use them climate models questions. Climate question. There's the 7 questions. So, for example, so what do you think has caused your the problem? What do you think it started when it hit? What do you think your sickness is to you? This is Arthur Kleinman is a very famous anthropologist in Harvard Medical Schools, and he has done a lot of research in Taiwan and also in China. And this is I use these 7 questions to encourage our students to think about the care of the patient during the entire process. And there's also another called a learn model. The model is called the listening, explained, acknowledge, recommended, and negotiate. This is one thing for communication for the culture difference. So we have to acknowledge the difference and to respect the difference. For the another most recent published in the Lancet Clinical Medicine, he mentioned about the incorporate the culture competence into graduate medical education. We just mentioned about the undergraduate, but now this is graduate medical education, including the course competence into the formal didactic curriculum, also including the communication training. The rotation should be, if that's possible, then rotate to the under surface area. They notice the difference of the culture barrier. And also there are a lot of activities, for example, just like the role play or celebration that we can learn about the culture issues during the process. This is the last line. I like this one. Health literacy. They put it as a core health literacy. That means that including the reading, writing, architectures, using the digital resources. And the second layer is the engaged health literacy, including the communication between the client and the health provider. So they use the skills about the problem solving and communication, making decision. And the highest layer, the top layer, including the independent environmental individuals and also the communities, addressing the 3 levels of health literacy. And this is the influential health literacy that not only interact with the health medical service provider, but also there are some interaction with our friends and disseminate information to our colleagues, the friends, our relatives, to make it more generalized of the health literate information to most of the people they can get in touch with. So for these 3 levels, we need not only the understanding of health literacy, but we also need to understand the culture within the communities and using the appropriate approach methods to improve the health, the quality of health in the communities. I think that this is the end of my presentation, and thank you for your attention.